Good morning, everyone. And in this lecture, we are going to discuss about the peripheral vascular diseases. Basically, there are two lectures. One is this one, which will discuss the arterial conditions, and in the next lecture, what we will discuss is the venous conditions. So, collectively, of course, like here it is written peripheral vascular diseases because um, there are two type of what you can say like if you will take the circulatory system, of course there is the heart, and from the heart, then there is a main trunk which arises, which is called as aorta, and of course the aorta gives the sub branches or the branches which are considered as the peripheral vascular system. So in this lecture, what we will be discussing is most like only the arterial conditions. In the next lecture, we will discuss the venous conditions. But of course, in the start of this lecture, what I will be going to discuss is the um, introduction about what these peripheral vascular diseases are. So, yeah, this is like two basic things. I think like all of you must know now, at least like after doing anatomy, how to identify. When we do dissection, we can identify either it's artery or it's a vein, and arteries are basically thick walled and they are not collapsed, whereas the collapsed one are the veins. I'm talking about the cadavers, right? So, uh, basically, arteries are having thick wall, and uh, this thing, of course, like all the vessels, they have the inner layer, middle layer, and as well as the outer layer. And arteries have like smooth muscles that contracts and relaxes to respond changes in blood volume, and that's how what you can say the tone is maintained in the vessels, and the blood pressure is also maintained. Whereas the veins are thin-walled vessels, and um, they have little smooth muscles and connective tissue, and because of that, the veins are more distendable. That's the reason that most of the blood in the body, in the circulation, is basically in the veins. And some of the veins, they have the valves, and that's one of the reason that there is no backflow. Okay, but of course, in this lecture, we are going to discuss mainly the arteries. Okay, so introduction to this one. Arterial conditions are more common in what you can say the developed world. Why? Because um, like in old age, especially, or as the person ages, there are what you can say different type of problem. One of the thing is called as atherosclerosis, and um, like whenever the due to atherosclerosis, the blood supply to the heart is stopped, so it can lead to myocardial infarction if the embolus or atherosclerotic plaque can block the blood supply to the brain. Stroke can occur. Same thing with the kidney and all the other structures. So of course, as there is myocardial ischemia, there can be stroke, there can be kidney ischemia, there can be mesenteric ischemia. Uh, so of course, when the limbs which are getting blood supply from the vessels, when they are blocked, of course, they can also get ischemic. So uh, now, whatever our discussion mostly will revolve around is around the atherosclerotic changes, embolism, thrombosis, stenosis, occlusion, and all these things. And that's one of the reason when we are going to discuss all these things, you would know that the risk factors for heart conditions, the risk factors for stroke, um, are more or less same, the stress factors for all these conditions. Okay, so you can see over here the factors that can contribute to the development of peripheral vascular disorders. So the same things, like you will find nothing new, like atherosclerotic changes, thrombus formation, um, embolization, increased coagulability or hypercoagulability, hypertension, inflammatory processes, and infections, right? So now Um in this slide, if you will see, like there is a difference between like what happens when there is any arterial insufficiency as compared to what happens when there is some uh, venous insufficiency. Now clearly it can be seen that and if you will use common sense, so see, arteries are those which are taking the blood from the heart to the tissue, whereas the veins are the thing which are uh, carrying the blood from the tissue to the heart, okay, or towards the heart, you can say. Now, see, whenever any tissue is not getting enough blood supply, or what you can say enough oxygen supply, that will lead to ischemia, okay. Um, on the other hand, when some tissue is getting enough blood supply to the tissue, but the drainage is blocked or is not proper. So what will happen that the blood will start accumulating that in that area, and it will lead to congestion. Okay, so this is the concept of uh, you can say the baseline concept. See, there is a not disease, sorry, decreased, okay, uh, blood flow towards the tissue, producing ischemia, right? Whereas here there is decreased return of blood from the tissue to the heart, which can lead to venous congestion and stasis of the blood. So, of course, when there is decreased blood supply to the tissue, and it will lead to ischemia. So, when we are going to do examination, what we are going to get is um, either decreased pulses or uh, diminished pulses or absent pulses. Anything can be there. Whereas in venous insufficiency, okay, uh, of course, because the arterial supply doesn't have any issues, so the pulses will be present, right? Same thing. Uh, now, when the blood supply is completely cut off, the area can be necrosed, and necrosis means what you can say a dead tissue, right? Um, Whereas, on the other hand, in venous insufficiency, of course, necrosis is not the is not going to happen. Rather, there is stasis of the blood, there is congestion of that area, so which will lead to other changes, which can be seen as edema, collection of the fluid. There will be certain skin changes, and there will be ulcer formations. Also, in arterial condition, there can be ulcer formation. Okay, one very important thing to what you can say, which you can make a concept. Uh, there is a mnemonic which is called as 6 P's. Okay, like P for pulse, P for pallor. So P for P for pulse, P for pallor, P for pain, P for paresthesia. Okay, and pain, paresthesia, pulses, pallor, for, and yes, one thing is perishing cold. Okay, so see, whenever you found that someone have pain in some area, okay, and that area doesn't have pulses, no pulses there, um, so pain is there, pulses are not there, and the area is pale, of course, because there is no blood supply. So pallor is there, uh, and when you touch it, you found it is perishing cold. The area is cold, not warm. Okay, and there is paresthesia. Paresthesia means what? Absence or altered sensations, right? So see, these are the things which basically we see on examination, and we can make a diagnosis, or we can make a conclusion that okay, this area is devoid, or this area doesn't have enough blood supply. Okay, so this is the main concept behind this thing. Okay, you can see these are the common comparison of characteristic of arterial and venous disorders. So now all the things which I told you, you will find most of the things over here. So this is for arterial conditions. These are for venous diseases. So what we see when we see the skin. So when we see the skin or feel the skin, it will be cold, it will be hairless, it will be dry because there is no fluid is coming towards that, shiny, it will be pale, and these things will be there. In venous conditions, it will be warm, it will be thickened, it will be mottled, it will be pigmented. Okay, why these changes are there? Just because of stasis. You know, when there is blood stasis, of course the blood have pigments, and that pigments, you know, they are going to ooze out from the vascular space, will go into the skin, and they are going to cause this mottling and pigmented areas, right? Pain in this case is sharp stabbing and worsen with activity, uh, and with activity like walking, lowering feet, and lowering feet may relieve the pain, right? Whereas in the venous ulcers, it will be aching, crampy type of pain. Okay, activity like walking sometimes help in this case, and elevating the feet relieves the pain, right? Because the elevation is going to increase the drainage. In this case, the elevation is going to uh, like what you can say uh, compensate, or decompensate, like the blood supply will be reduced when you are going to elevate. So that's why lowering the feet may relieve the pain. In this one, elevation of the feet relieve the pain. Okay, so ulcers form in both arterial and as well as venous conditions. In arterial conditions, the ulcers are painful, and like severely painful. They are pale, they have gray base, and they found on the extremities, like the tip of the fingers, the tip of the toes, like this way. Here, the ulcers, they are pinkish in color, they have pink base, and they okay. This is a very, very, very important point to remember. You know, the ulcers of the or the venous ulcers, they are basically present in the medial side of the leg above the medial malleolus. Okay, this is very typical about the venous ulcers. So pulses will be absent, and here they will be present, and edema here there, like, it will not be present or infrequent, but here it will be frequent. Okay, now a very important concept to understand over here, because we are going to study arterial condition in this one. um, there is one thing which is called as wait, let me check if there is here it is present or not, or okay, one thing is called as intermittent claudication. Okay, or you can say claudication. Okay, what is claudication? Now, claudication is a cramp like pain, okay, which the patients feel. Now, there is something called as claudication distance. Now, see, right now you have good blood supply to your lower limbs, and that's why you can walk, you can run, you can do whatever activity you want, and you will not feel any pain. But what is going to happen when this blood supply is compromised? Okay, for example, some part of your artery is half blocked, or you can say 75% is blocked. So now maybe when you are at rest, your tissues are getting enough perfusion, there is no sign or symptoms. When you started walking, maybe still the tissues are getting enough perfusion, no issues. So there is no rest pain, there is no pain on walk, but as soon as you will start running, now the blood supply cannot be increased to such an extent to supply the demand over there in the tissue. So what will happen? Your muscles will started having the cramp like pain. Okay, so okay, now whenever we check the patients in the hospitals or in the clinics, we ask the patient to walk, and when the patient walk, sometimes the pain will come after walking few uh, like some distance, and we call it as claudication distance, right? So okay, so remember this claudication pain is coming because of what? Because there is not enough perfusion. So remember this thing, that claudication or intermittent claudication is brought up on activity and relieved by giving up that activity. Okay, so when we ask the patient to walk, okay, uh, walk, and we check how much the patient can walk. Okay, so of course the distance the patient can walk is called as claudication distance. Okay, so this is very important thing to remember in this one. Okay, so basically this claudication pain is mostly felt around the calf and in the buttock. So buttock claudication is often associated with sexual impotence. Okay, because there is decreased blood supply to that area, so the person, they cannot get erection. Okay, and that is called as larynx syndrome. And same thing, the claudication can be of arm claudication and things like this. Now one very important concept about claudication, okay, which is what? If the patient just have pain on running, it means that patient is better than someone who have pain on walking, which means that person have less claudication or less claudication distance or less blockage compared to the patient who have pain on rest. So remember guys, when there is someone have pain on rest, like when the person is not doing anything, still they have pain in that area. It could be lower limb, it could be upper limb. Okay, so that pain can be exaggerated by laying down or by elevation of the foot. Why? Because you are the blood supply will be compromised even more when you are going to elevate the limb of that person. Okay, so uh, this is one of the thing, and we say that this is called as rest pain. Someone who have pain on rest, we call it as rest pain, and it means like the person have a serious type of condition, right? And basically these patients have more pain during the night because they lay down to sleep. And when you ask in the history that what relieves the pain, they say, whenever we uh, hang our feet on the side of the bed. Okay, and rest of the things I already told you. Okay, we can check the temperature. They may have paresthesia. They have numbness. Okay, that area is cold. Okay, and all these things. So and there will be no pulses. Okay, so these are all the examination findings which we are going to do in that patients. Okay, so this is called as claudication. Now I told you because most of the things are basically connected with uh, atherosclerosis, right? So the risk factors for heart condition and for these conditions are more or less the same thing. You can see over here: old age, males, cigarette smoking, hypertension, hyperlipidemia, obesity, right? So see, lack of physical activity, emotional stress, diabetes mellitus, and history of atherosclerosis. So they have almost the same uh, risk factors. So if you can remember the risk factors of myocardial infarction, uh, basically you remember that what you can say, the risk factors for all the arterial conditions, right? Okay, so now we are going to study these conditions one by one. Okay, now the conditions aren't too much, and of course, like I gave this lecture many times in the class, and like excluding break, the lecture is around uh, as a whole, like there is 1.5 of a lecture, 10 minutes break, so 1 hour 20 minutes, and then the students ask questions, so we waste a lot of time in the class. So basically in that time I usually cover all the conditions, okay, of this one. So basically there is a lot of conditions, and of course when you will study more details when you will study it from the books, right? So you can see like the first one, which is called as atherosclerosis obliterans. So now, as the name shows, there is atherosclerosis, and which is blocking the flow of the blood. Okay. So this one is the most common cause of arterial obstruction in the extremities, and the lower are more involved than the upper one. Okay. And the common sites are femoral arteries, iliac arteries, popliteal artery. Okay. And in a diabetic, the disease become more progressive, affect the smaller arteries and often vessels below the knee. You can see over here, like this is the normal blood supply of the brain, of the lower limb, and you can see like if someone had atherosclerotic buildup in the what you can say, in the artery. So what will happen, of course, like below here, all the blood supply will be compromised, and the patients will be having again the same story. uh, Okay, this is the pathophysiology of atherosclerosis. I think you have already covered in pathology. So the patient will present with simply. Now, if you know what is claudication, so you can say the patient can present with intermittent claudication. Now, the important things is what? That it's not like this that, this is the only cause, but okay. Of course, it's a slow process, right? Atherosclerosis cannot occur in one day. It will be ongoing, and with time, of course, what will happen that it is going to block all the vessel, right? All the way. So the patient will present in this way, that before he was a little better, before his stamina of walking, he can walk more steps, he can walk more distance, he can go maybe 2 or 3 flights of stairs. But now, as the time is passing by, he is going, like his condition is becoming bad. Now before maybe he can walk 1 kilometer without any pain, but now he can walk maybe 600 meters, and then the pain started. Okay. Now, this is not the only way by which this thing can occur. See, if the history goes like this way, it means it's atherosclerotic plaque. But what if the patient presenting with the same symptoms? I'm not reading all this, but because I have discussed these things already. For example, the patient is presenting with the same features, okay, but the patient is saying you that this thing started all of the sudden yesterday. Okay, so this one is having this atherosclerotic obliterans have a subacute or chronic onset. But what if the patient is saying that 3 days back he was fine, yesterday all this thing happened, so now it is an acute onset, right? So see, atherosclerotic plaque cannot develop in one day, right? Now you have to think about the acute causes. What could be the acute cause? Very simple. Now it means that it is some sort of embolus or thromboembolic type of condition, which basically, or maybe, okay, maybe it could be it could be this thing that the patient was having atherosclerotic plaque already, but now suddenly there was thrombus from somewhere, okay, and it came and it blocked all the way, okay. You know what is embolus? Embolus, thrombus, when the thing which started traveling we call it as thrombus. Okay. So now, if the condition is thromboembolic type of condition, see, all the paradigm is changed. All the uh, story is changed. Why? Because you must now see from where the thrombus can come. It can come from heart, for example. Atrial fibrillation, thrombus can form. If the thrombus will go into the coronary vessels, will result into myocardial infarction. If the thrombus will go into the brain circulation, stroke can occur. The thrombus can go into the GIT circulation, mesenteric ischemia can occur. The thrombus can go into the renal circulation, renal infarction can occur. So in this case, of course, the thrombus, maybe atrial fibrillation, the thrombus started and it is blocking a vessel which is supplying some important part of the body like the lower limb, for example. Okay, so you have done myocardial infarction, so all the thrombus which can arise from somewhere and cause myocardial infarction, same story works here. Okay, so remember, acute onset, chronic onset will give you answers, okay, and will teach you what to do. Okay, what is a diagnostic test now? See, a very, very, very important thing is available, guys, and a very easy to do. That is called as Doppler's ultrasonography. Doppler is a handheld device. It can, and there is one thing called as color Doppler as well. So basically, what it can tell you is the flow. Okay, it can notice the blood flow in the vessels. Okay, so basically, whenever in the hospitals anyone presented with this presentation, and we are suspecting that one of the artery is blocked, we can quickly do Dopplers, and the Dopplers can tell us, or by Doppler we would know that there is some blockage. Of course, you will take history, it's acute onset, it's chronic onset. You can do examination, pulselessness, pallor, pain, paresthesia, perishing cold, right? You have done these things, you have done Doppler, your diagnosis can be done. Okay, so this is called as Doppler's ultrasonography, right? Okay, how we treat that? Okay, now the treatment is different, guys. The treatment is different if it's a thrombus. The treatment is different if it is just atherosclerosis or it's a chronic onset. For example, we can use a vasodilator, we can do a surgical intervention. In surgical intervention, the thing which we will do is embolectomy. Okay, by the way, when the patients reach the hospital, so what they do, as soon as they know like they have some thrombus formation, they start the patient on heparin. Okay, once they have started heparin, then they decide either what to do. So one of the thing is embolectomy. So what is embolectomy? Of course, they have to remove the blood clot from that artery. Okay, and of course, like it's a very common, easy thing. Like they can just give an incision to that area, to that vessel, take the clot out, and just fix it back again. Okay, so it is called as embolectomy. Then there is something called as endarterectomy. Okay, so what is endarterectomy? Simply, when they have to remove the atherosclerotic plaque, we call it as what? Endarterectomy. Okay, now one of the things they can do is arterial bypass surgery. So you know what is bypass surgery? Like, okay, I will show you arterial bypass surgery over here. See, if you want to, if the thrombus is over here or the atherosclerotic plaque is over here, so they are going to connect this here vessel with this one. So they are creating a bypass for the blood flow. Okay, They are creating a bypass. So this is called as arterial bypass surgery. So they can use a synthetic material or prosthetic, like something which is what you can say formed in man-made thing, or they can use a person's own artery like long surface vein. Okay, anything can be done. So this is called as arterial bypass surgery. One of the things they can do is also called as intra-arterial thrombolysis. Okay, in that one they give TPA, tissue plasminogen activator. Okay, so this thing. And remember guys, if the occlusion is complete, number one, and number second, much of the time is passed away, then the tissue can be necrosed. And remember, like necrose means dead tissue. So if any part in the body is necrosed or dead or gangrene have developed, okay, necrosis, it become black, gangrene, then the only solution is amputation. Okay, if the limb is gangrenous, amputate it, remove it, cut it. Okay, so that is like another thing. Gangrene, I think you guys know what is gangrene, and we know like how gangrene looks like, right? There are two type of gangrenes, dry gangrene and wet gangrene. So anyhow, like then the only solution is simply we have to do amputation. Okay, in that case only amputation is the only thing. And amputation, of course, like it depends on which area is affected. What they do, like they remove that area, they cut that area, and simply later on they decide either some prosthesis can work or not. Okay, so amputation can do. This is endarterectomy, right? So see, they are stripping off the clot. So this is a plaque, incision. So okay, percutaneous transfemoral angioplasty can be done, and amputation, as I told you, right? If whenever there is any gangrene, of course, amputation is the only thing. Okay. Okay. So this one is like more about the amputation things. Okay, and like how to grade the things. Condition of the skin, you will see like any ulceration, necrotic tissue. Okay, you will see like if it is extremely cold to touch, you will check the peripheral pulses. You are going to grade them: full and bounding one, normal pulse, weak and thready or absent. Okay, you will check the capillary refilling time, and you will check the muscle tone. Okay, so this one. So now this one is like monitor the limb. Like this is the acute care which we have to do. Monitor the limb distal to the affected area. Site for changes in the color temperature, and decrease arterial flow, pale and cool initially, bluish or darker, tissue become necrotic and black, depending like what is the condition. Okay, so we can give some vasodilators. Okay, they decrease the pain. We can do some comfort measures for the patient, like body posturing and all this stuff. So this thing. And this is the post-surgical care of for that patients. Like of course the patient should be monitored. We must check the skin color and temperature. After the surgery, we must assess their peripheral pulses and assess their wound for redness, swelling, and drainage. We must promote circulation and prescribe them medication with to reduce pain. Okay, so now again, like these are the details of what can be done for arterial bypass surgery, right? Think this thing. Okay, one of the thing, I'm not going to talk about this condition in too much detail, but what this condition is called as you can see, Thromboangitis Obliterans. It is also called as Buerger's disease, right? Okay, now this condition is basically again obliterans, like Obliterans, if you know like what it means, like the place is obliterated, right? Blocked. So this one is basically a disease in which like there's occlusion in the small and medium sized arteries like plantar, tibial, radial, and this one. Okay. Now, the very important association of this thing is like this condition is very common in the males, especially who smoke and who are around 30 years of age. Very easy to remember, okay? And very interesting disease, right? So, and it usually, like, there is something called as Raynaud's phenomena, right? You can see over here. Okay. When it affects the upper limb arteries, so see, this is how the patient present, Raynaud's disease. Like, okay, Raynaud's disease, and what is the difference between thromboangitis obliterans or Buerger disease or Raynaud's disease? Raynaud's disease is more common in young women and it affects the hands more than the feet, okay? And they have this arterial constriction in response to cold, okay? So whenever their hand is exposed to the cold, there, see, this finger is fine, but this finger, there is constriction, okay? I'm talking about Raynaud's disease. This one, of course, this photo is the photo of thromboangitis obliterans, okay? You can see over here, what are the clinical features? They have intermittent claudication if it is affecting the foot, pain during rest, coldness, same thing. There is no difference, okay? But what I'm talking about is, I'm talking about Raynaud's disease, right? Raynaud's disease and Buerger disease. See, in Buerger disease, it is occlusive disease. There is occlusion, right? Raynaud's disease is common in females, young females, okay? And what happens is, by the way, in response to cold, their arteries or the arterioles in their hands, they become constricted, okay? And due to that constriction, their fingers, see, if you see your hand is red. But when, for example, you have the constriction of artery, so what happens? Their hands turns white, okay? And this is what happened in their digits, okay? So their digits become swollen and see a little dusky color, okay? And after some time, when the attack is finished, the arterioles, they relax and the oxygenated blood, it started coming back, okay, into the arterioles, into the capillaries, and the digits become red again. So remember guys, in response to cold, in response to stress or anything, they have the attacks of Raynaud's disease, okay? And this is how we diagnose that they have cyanosis of fingers, okay? Sometimes they have pain also. And one of the thing, if you will see over here in thromboangitis obliterans, they have necrosis, okay? In Raynaud's disease, necrosis is not common, okay? Necrosis don't occur in this one. In thromboangitis obliterans, necrosis can occur. So now, like this is called as Raynaud's disease, okay? Now, okay, and don't confuse Raynaud, like there is something called as Raynaud's syndrome as well, okay? Now, okay, so Raynaud's syndrome is a syndrome which is basically associated with certain, what you can say, collagen vascular diseases like systemic lupus erythematosus or rheumatoid arthritis, okay? And, but you know, Raynaud's syndrome is more aggressive than Raynaud disease, right? So anyhow, leave that. So this is Raynaud's disease and this is thromboangitis obliterans, okay? The features will be same of occlusion, like which we have already covered, right? So the features are same like what we have discussed before, okay? Okay, so of course, what are the interventions which we can do? We can ask the patient to stop smoking, use vasodilators, prevent progression of disease, avoid trauma to ischemic tissue, relieve pain, provide emotional support. Okay, this thing uh, I include here because I like, if you do a little research, you will found like in some of the patients it works. So basically you can remove this, okay, if you, because I think like, because maybe you will not find it in much books, so that's why I'm removing it. So we ask the patient to avoid any mechanical, chemical, or thermal injuries to the tissue of feet, and amputation, of course, if the area is gangrenous. Remember, guys, whenever there is any necrosis or gangrenous tissue, the only treatment is amputation, right? Then comes the Raynaud's phenomena or Raynaud's disease. As I already told you, this thing that intermittent episodes during the small arteries of or arterioles of right or left arm constrict, causing changes in skin color and temperature. Generally unilateral and may affect only one to two fingers, and may occur after trauma, neurogenic lesions, or occlusive artery disease, connective tissue disease. So this one, remember, it is more common in females, right? It's a very favorite type of question, in many of the exams. So that's why. So the clinical features will be same. Remember, the necrosis is not so common; it's very uncommon. Okay, and but the features will be same. They complain of pain, they complain of uh, cold area. They like, you will, when you found like it will be cold, there will be paresthesia or tingling sensations and things like this, right, in these patients. So this is how they present. Again, you can see the dusky colored skin here and here, right? Raynaud's disease. So medical management aimed at prevention. So we ask them to avoid any thing which bring this thing, like sudden temperature changes, avoid cold, quit smoking. We can prescribe them with calcium channel blockers, smooth muscle relaxants, vasodilators, and the ultimate treatment is, see, one of our, like in patients like in which it is refractory to these things, sympathectomy, like the sympathetic nerve supply is cut off. Okay, that is the one which causes constriction, if you know. So that is the thing which can be done in these patients. Okay, next to that, okay, so the same thing, I'm not going like, see, quit smoking, avoid stress, provide comfort, avoid exposure to cold, wear adequate clothing to promote warmth, wear gloves and socks, avoid cleaning any refrigerators, freezers, or handling of frozen foods. Avoid drugs, especially, which have vasoconstriction effect, of course. This is very important, right? Suggest anti-inflammatory analgesics to promote comfort. Okay, so the last thing which we are going to discuss in this lecture is aneurysms, and it's a very important topic. Now, aneurysm, which we know, like it is a localized dilatation, okay, or protrusion, okay, of any vessel. We call it as aneurysm. And aneurysms, they can be anywhere. They can be even in the brain. And if you know, like one of the aneurysm, which is again a favorite MCQ question for many exams, is called that. It is called as Barry's aneurysm. So aneurysm is a localized or diffuse enlargement of an artery at some point. Can occur when the vessel becomes weakened after trauma or congenital vascular disease or infection and atherosclerosis, right? So now, what type of aneurysm we are going to discuss in this lecture? Basically, we are going to discuss AAA, okay, or abdominal aortic aneurysms. By the way, there is thoracic aortic aneurysm as well. Okay, we will discuss that also. So now, these are different type of aneurysms: saccular aneurysm, fusiform aneurysm, and dissecting aneurysm. And of course, how we diagnose them, we do chest x-ray, we do ultrasonographies, right? So you can see like a saccular one involve the whole circumference, okay, and sorry, only the part of the circumference, and fusiform, it's spindle shaped, involves the entire circumference, and dissecting one is the one which basically dissect the wall. Okay, so the aneurysms can be classified according to the wall. There is true aneurysms, there is false aneurysm. True aneurysm is that one which involve all the three layers, intima, media, and adventitia. And false is the one which just involve one layer. Okay, and they can be classified according to this one, secular form, fusiform, or dissecting, or they can be classified according to the etiology. Okay, like which result due to atherosclerosis, which result due to trauma, which result due to collagen vascular diseases, or which can be congenital. Okay, congenital vascular diseases, as well as I would add something here, collagen vascular diseases like Marfan syndrome, and there are many more. Okay, Marfan is, by the way, congenital. You can say many of the, what you can say, rheumatological conditions, right? Okay, now you can see over here, this is the example of Barry's aneurysm. Okay, and this is abdominal aortic aneurysm, and this is like the aortic dissection, you can see over here. Okay, so okay, abdominal aortic aneurysm is the most common one. Okay, abdominal aortic aneurysm is the most common one. Okay, so now of course, like we will discuss abdominal aortic aneurysm in detail, but here of course you can see like there could be thoracic aortic aneurysm, and aneurysm in the thoracic area, and it occurs in most of the hypertensive males from 40 to 70 years of age, and it can develop in ascending, transverse, or as well as descending aorta. How they present? They present with chest pain, which basically goes backward. Okay, which radiates backward. A cough, dyspnea, hoarseness, dysphagia, these are all pressure symptoms. When there is aneurysm formation, of course the aneurysm is going to cause pressure on the adjoining structure, so it can lead to this thing. Okay, so you can see like this is the photograph for thoracic, and this is the abdominal aortic aneurysm. I told you this is the most common type of aneurysm, and it is so common that when they conduct autopsies, 2% of the autopsies they have abdominal aortic aneurysm. Okay, and 95% of the time it is associated with atherosclerosis, and 95% of the time it occurs below the renal artery. Okay, and most of the time it doesn't give any sign and symptoms. Sometimes it do give some abdominal pain and things like this. Okay, but most of the time they are asymptomatic. Okay, so now the most important thing to remember about this one is like whenever we found any abdominal aortic aneurysm in any patient, we check the size of that aneurysm. Okay, and there are guidelines to how to deal with that. For example, if someone have less than 5 centimeter of aneurysm, we do follow up. Like the guideline is not so simple, of course. It depends like how much is the size. So either they need a follow up after 1 year or 6 months or after a month, like this. But just to tell you, like follow up is needed. Why? Because as the aneurysm is getting bigger in size, they can rupture. Okay, so remember, aorta is a big vessel, and imagine when it will rupture. Okay, so basically whenever it ruptured, the mortality is very high. Okay, so you can say anyone who have rupture of abdominal aorta, basically half of the people never reach the hospital, they die before that. Okay, because there is a huge bleeding, and the patients who become hypotensive and they cannot survive. Okay, and mostly anterior ruptures, because there is more space for bleeding in the abdomen, because in posterior rupture there is retroperitoneal bleeding, so maybe there is some tamponade and the bleeding can stop. But the important thing is this thing. So anyone who have a pulsatile abdominal mass on palpation or pain or tenderness in the mid or upper abdomen, and whenever we diagnose them with the what you can say abdominal aortic aneurysm, so what is important is to repair that. Okay, sometimes this, like, it's not always silent, sometimes it do become symptomatic. So in that one, of course, like, this is most of the time it is asymptomatic, but whenever it is symptomatic, these are the symptoms which are written. Okay, sometimes they have gastrointestinal, urinary and venous symptoms as well. So this thing is important. So in that case, whenever we diagnose anyone with symptomatic, what you can say, or asymptomatic abdominal aneurysms, then we go for surgery. Okay, we repair that. So of course, like, surgery is not so simple, and nowadays, but the things are good and we have a lot of options. Like before, what they used to do is like a open surgical procedure, like they uh, open all the, what you can say, abdomen, and they approach the aorta, and then once they reach the aorta, what they do is like they they repair it, right? So they repair it. So again, like, it's not that much simple. Like, of course, it's a huge procedure, but nowadays the good thing is we have uh, uh, new procedures, something called as endoluminal procedures. Okay, by which this one is repaired. So you can see over here, like, this is the repair of the aorta. Okay, this is the repair of the aorta, in which, like, they are putting a stent graft. Okay, so this is like the endoluminal procedures are very popular nowadays, and why? Because they can assess aorta through the femoral arteries, and again, through that, they can put this stent or the graft. Okay, mostly it is made up of dacron. Okay, so nowadays the thing is quite easy to repair. So of course, like, there are some complications, but the results are very good, and the surgery is not so interventional. Okay, the risk factors are less. Okay, so uh, uh, like, this is how they repair that. Okay, repair this one. Okay, and this one is like the arterial embolization, which I discussed in the start. This is the explanation of that. Okay, and then there is venous disorders. Okay, so not just this, of course, like, aneurysms can be formed at other places as well, like femoral aneurysm can be there, popliteal aneurysm can be there, but of course that thing we are going to discuss later. So I hope you understand this lecture, and in the next lecture what we are going to discuss is the venous conditions. Till then, thank you so much.